there since birth, but later on the problem appeared. So we are going to discuss what are the causes of congenital hypothyroidism and what are the causes of acquired hypothyroidism. And hypothyroidism, as the name indicates, in this condition, the production of thyroid hormone is decreased. So there is decreased amount of thyroxine in the blood. Hypothyroidism. Hypothyroidism results from deficient production of thyroid hormone. यहाँ spelling mistake है, A नहीं है, O होना चाहिए. So hypothyroidism results from deficient production of thyroid hormone or in defect in thyroid hormone receptor activity, meaning that the thyroid hormone is produced properly by the thyroid gland, but when the thyroid hormone is reaching to the cellular level for its actions, there is deficiency of the receptor there, and that is why the end result, that is the action of thyroid hormone, is not visible. Hypothyroidism results from deficient production of thyroid hormone or in defect in thyroid hormone receptor activity. Now the epidemiology. Hypothyroidism can be congenital. Thyroid dysgenesis affects 1 per 4,000 newborns worldwide. Hypothalamic or pituitary insufficiency. इसमें पैटर्न में चेंज हो गया, ऐसे लिखना चाहिए था पिट्यूटरी और hypothalamic insufficiency, which results in secondary or tertiary hypothyroidism respectively, affects 1 per 60,000 to 1,40,000 न्यूबॉर्न्स वर्ल्डवाइड. तो आप देखें कि जो मेन इशू है वो प्रॉब्लम ज्यादा देखा जा रहा है प्राइमरी हाइपोथायरॉयडिज्म में, वेयर द फॉल्ट इज इन द थायराइड ग्लैंड. तो जहां थायराइड ग्लैंड में फॉल्ट है, जैसे प्राइमरी हाइपोथायरॉयडिज्म, वहां आप इंसिडेंस देखें तो 1 per 4,000 है, यानी in each 4,000 newborn babies, one baby will be hypothyroid because of thyroid dysgenesis. But as you see, the incidence of secondary or tertiary hypothyroidism, meaning that when the problem is in the anterior pituitary or the problem is in the hypothalamus, that can also lead to hypothyroidism. But the incidence of that sort of hypothyroidism appearing from defect in either in the pituitary or the hypothalamus, that incidence is very low, 1 per 60,000 to 1 per 1,40,000 newborns worldwide. So the commonest reason of hypothyroidism that you see is because of the primary hypothyroidism, that is the fault is in the thyroid gland. This should be very clear. What do we mean by primary hypothyroidism and secondary hypothyroidism or tertiary hypothyroidism? If the fault is in the thyroid gland, it will be considered as primary hypothyroidism. If the thyroid gland is okay, but the problem lies with the anterior pituitary, then you say it is secondary hypothyroidism. But for example, the thyroid gland is perfectly all right and anterior pituitary is also okay, and the hypothalamus is not producing thyrotropin releasing hormone from that place, then you say it is tertiary hypothyroidism. So one should be very clear about what do we mean by primary, secondary or tertiary hypothyroidism. When the fault is in the thyroid gland, it is primary hypothyroidism. When the fault is in the anterior pituitary, it is secondary hypothyroidism. And when the fault is in the hypothalamus, it will be considered as tertiary hypothyroidism. So the incidence of hypothyroidism secondary to pituitary or hypothalamus is very rare, but the incidence of hypothyroidism secondary to primary hypothyroidism is much more, as you can see, 1 per 4,000 newborns. Hypothyroidism can be acquired. As many as 10% of young females are estimated to have some signs of autoimmune thyroid disease, usually chronic lymphocytic thyroiditis. Now the mortality and morbidity. Untreated congenital hypothyroidism in early infancy results in profound growth failure, and disrupted development of the CNS, leading to developmental cognitive delay. And the condition is called cretinism. So if there is congenital hypothyroidism, you will see a baby with the cretinism. What is cretinism? And you see a child who is having profound growth failure, and as well as who is having severe developmental cognitive delay as well. So it is very important that one should diagnose congenital hypothyroidism as soon as possible in the early infancy, because if you give the child thyroxine from the early stage of life, then it will protect the child from developing cretinism. But God forbid, if you don't diagnose the congenital hypothyroidism at the proper time, and maybe the child comes to you at the age of 1 year with delayed milestones, and then you investigate, by that time most of the damage has already taken place. Okay, you will give treatment and it will give some improvement, but that most of the damage has already been taken place. So that is why it is very important to learn this topic, congenital hypothyroidism, because if you diagnose congenital hypothyroidism at as early as possible, it will be more beneficial for the patient. Untreated hypothyroidism in older children leads to growth failure, as well as slowed metabolism and impaired memory. So the timing is very important. If the congenital hypothyroidism is since birth, the chances of developmental delay will be much, much more as compared to someone who developed hypothyroidism not in the neonatal age or infantile age, but in older age. In that case, the damage will be much less as compared to the condition when the child was having congenital hypothyroidism. Regarding the sex, thyroid dizziness, as we know, it is one of the cause of primary hypothyroidism, where the fault is in the thyroid gland. Thyroid dysgenesis occurs more frequently in females than in males, with a female to male ratio of 2:1. Chronic lymphocytic thyroiditis also has a 2:1 female to male preponderance. So over here you can see that the females are more prone to develop hypothyroidism as compared to males. Now the age. Congenital hypothyroidism can present with goiter at birth or with the gradual development of symptoms over the first several months of life. Chronic lymphocytic thyroiditis typically presents during adolescence. However, it may present any time in life, but usually chronic lymphocytic thyroiditis is seen in adolescence age group, while congenital hypothyroidism, as the name indicates, is seen at the time of birth. It could be associated with goiter or without goiter. And goiter is, what is goiter? Goiter is an enlarged thyroid gland. Now, what are the clinical features of hypothyroidism? Most infants with congenital hypothyroidism are asymptomatic at birth due to transplacental passage of moderate amount of maternal T4, which provide fetal levels that are approximately 33% of normal at birth. So in the first few days of life, even if the child is having congenital hypothyroidism, that child may not be picked up because some of the T4 from the maternal side has transferred through the placenta to the baby, and that will be fulfilling the requirement of the child in the first few days of life. But when that supply line is broken down after a few days, the hypothyroidism will start showing its manifestations. Now, what are the clinical features in neonates that if we notice these sort of clinical features, we should suspect that this neonate might be a case of hypothyroidism. And one should be knowing what is a neonate. Neonate is the first 28 days of life. From the birth till 28 days of life, this period is called neonatal age. So in this slide, we are discussing the clinical features in neonates, meaning those babies whose lifespan is from birth till first 28 days of life. So in these sort of babies, you will see prolongation of physiological jaundice. What is physiological jaundice? It's a physiological jaundice is the jaundice that appeared on the day 2 or day 3 of life, reaches its peak at around 6 to 7 days, and by about 10 to 12 days, it disappears. It's a normal physiological jaundice. But if that physiological jaundice gets prolonged, for example, the child is 21 days of age and is still having jaundice, then one should start suspecting why this physiological jaundice of this child prolonged so much. Then you should think that could be this is one of the clinical feature of congenital hypothyroidism. Let me check the serum TSH level of this child, and if the serum TSH level is increased, then you will diagnose that okay, this is the problem. This patient is having this prolongation of physiological jaundice because of congenital hypothyroidism. Other clinical feature could be feeding difficulties, lack of interest, somnolence and choking spell during nursing, respiratory difficulties due to large tongue. Usually congenital hypothyroidism, you will see a large tongue, and that produce difficulty in respiration. So respiratory difficulties due to large tongue include apneic episode. What is apneic episode? And there is a cessation of breathing for more than 20 seconds or more, with or without bradycardia or cyanosis. So in babies with the neonatal congenital hypothyroidism, you will see may see respiratory difficulties due to large tongue, and it include apneic episodes, noisy respiration, nasal obstruction. So if the mother complains that my baby is very lethargic, there is nasal obstruction and there is difficulty in feeding, and its jaundice is not settling down even when this child is now 21 days of age or 14 days of age for that matter, then you should think that might be I'm dealing with a case of congenital hypothyroidism. Signs and symptoms of congenital hypothyroidism is poor appetite, constipation, large abdomen and umbilical hernia may be present, hypothermia, extremities may be cold and mottled, and slow pulse, cardiomegaly, and asymptomatic pericardial effusions are common. One should be very clear about constipation in uterus. Usually the babies who are on breastfeeding, they pass maybe 6 to 8 loose motions, 6 to 8 motions after every feed. Once the baby is breastfed, the baby passes the stool. So if you see a mother bringing you a child with the baby with the complaint that my baby is passing 6 to 8 stools per day, you can give her confidence that nothing wrong with this. This is normal in the neonatal age. Those babies who are on breastfeeding, they do pass stool after breastfeeding. This is normal, and who is on breastfeeding may pass 6 to 8 soft stools. Nothing to worry. Similarly, baby who is on breastfeeding might pass stool after 2 or 3 days or 4 days or even 6 to 8 days. That will not be considered as constipation as long as the baby is comfortable, abdomen is soft, and the baby who is passing the stool, say after 6 or 8 days, which is soft in consistency, you will reassure that this happens normal in newborn babies, that they may pass stool after 4 days, 6 days, 8 days, as long as they are soft and not bothering the child, nothing to worry. But for example, if the baby is really constipated and the baby is passing hard stools, then yes, you should consider in that neonate congenital hypothyroidism as a cause. Now, after discussing the clinical features of hypothyroidism in neonates, now we will be discussing the clinical features in infants and children. And if you see an infant or children, what is an infant? Infant is in the first year of life. First year of life is infant, and after the first year of life, then the uh, uh, child is considered as in the child category. If you want to know what is the age classification, so first 28 days of life is a neonate. In the first year of life, the child will be considered as infant. If the child age is between 1 to 3 years, this age is called the toddler age, and 3 to 5 years is a preschooler age, and 5 to 15 years is the school going age. Excuse me. So in infants, meaning that the children who are less than 1 year of age and more than 1 year of age, these are the findings that you should start thinking that might be I'm dealing with an infant or child with congenital hypothyroidism. And the signs are macrocytic anemia, meaning that the RBCs will be large in size, short stature. the height of the child will be less according to the age. Widely open anterior and posterior fontanelle. Normally, anterior fontanelle is present at the time of birth. It is open about 2 centimeters, and that could they get closed by 1.5 year of age. But supposing you are seeing a 1-year-old child and still the anterior fontanelle is widely open, and the posterior fontanelle usually that is closed at the time of birth or usually closes by the age of 3 months. If you see in a 1-year-old child anterior fontanelle are widely open and the posterior fontanelle is still open, that is one of the clinical feature that should make you think of possible hypothyroidism. Similarly, mouth is usually open with protrusion of thick, broad tongue, and there could be depressed nasal bridge, and there could be delayed dentition. There could be neck which is short and thick. And if you see the hands of these infants and children who are having hypothyroidism, hands will be broad, and the fingers will be short. And there will be myxedema of eyelids. Myxedema is a situation that develops because of hypothyroidism. There is edematous feeling, but when you press it, it is having non-pitting type of edema. Normally, the edema is of two types, pitting and non-pitting. In hypothyroidism, it is non-pitting type of edema. When you press, there is no pit is formed. You see, it's a non-pitting edema mostly because of myxedema. And the edema that is secondary to, for example, nephrotic syndrome or some other reason, in which there will be pitting edema, that you will feel a depression when over the just above the medial malleolus. So mixed edema of eyelids, back of hands, and external genitalia will be having mixed edematous picture. Second, carotenemia. What is carotenemia? Carotenemia is yellowish discoloration of skin, but in this condition, they remain white. This is how you differentiate anemia from jaundice. In the jaundice, there will be yellowish discoloration of skin as well as sclera. While in kidney there will be yellow discoloration of skin, but the sclera remain white. So in if you see a baby with macrocytic anemia, short stature, widely open anterior and posterior fontanelle, mouth is usually open mouth, broad tongue, depressed nasal bridge, delayed dentition, short neck, broad hands and short fingers, and mixed edema of eyelids, back of hands and external genitals, and you see carotenemia, and you observe hoarse voice of that child, and you see pallor skin with sallow complexion. All these are the clinical features that you expect to see in a child with hypothyroidism. Beside this, there will be developmentally delayed milestones. The child will be appearing late. For example, normally, at 3 to 4 months, there should be neck holding. At 6 to 7 months, there should be sitting. At 9 months, the baby should be able to stand with support. And by the age of 1 year, the child should be able to stand without support. And between 12 months to 15 months, the baby starts walking. But if you see, say, a 1-year-old child with hypothyroidism, the mother will complain, Dr. Sahab, मेरा बच्चा तो अभी बैठता भी नहीं है. तो आप कहेंगे your child is developmentally delayed, because normally a child should be able to sit by the age of 6 to 7 months, and your child is 1 year of age and still not sitting. Let me check it for hypothyroidism, because this is one of the cause of delayed development. And physical and mental retardation you can observe in that child, and there will be delayed sexual maturation. So after knowing the sign and symptoms of hypothyroidism in neonates and sign and symptoms of hypothyroidism in an infant and child, now there are certain photographs for you. In this photograph, what you can see, this is a child with enlarged tongue, and you see the lethargic appearance on the face. In this child, you can see the umbilical hernia, coarse facies. So it's a typical facies that you can see in an infant who is having hypothyroidism. And you can, by looking at the child, you can say maybe this patient is having hypothyroidism because of the sallow complexion, because of the enlarged tongue, because of the umbilical hernia, and lethargic look. Same hypothyroidism. Now, after knowing that what is hypothyroidism, what is primary hypothyroidism, what is secondary hypothyroidism, what is tertiary hypothyroidism, and what are the signs of hypothyroidism in a neonate, what are the signs of hypothyroidism in an infant and child. Now we should be knowing that what are the causes of hypothyroidism. So you can divide the causes of hypothyroidism into two categories: congenital hypothyroidism, when the fault is since birth, or acquired hypothyroidism, when meaning that the thyroid gland was okay at the time of birth. Later on, something happened to the thyroid gland that resulted in acquired hypothyroidism. So let us discuss first the causes of congenital hypothyroidism. Most common cause is this thyroid dysgenesis, as we have discussed in the earlier slide, that 1 in 4,000 cases of newborn babies do have thyroid dysgenesis, and this is the most common cause of congenital hypothyroidism. But we should be familiar with the rare causes of congenital hypothyroidism as well. At least we should be knowing the names of them, if not the details of it. So the second group of causes of congenital hypothyroidism is इनबॉर्न एरर ऑफ थायराइड हार्मोन सिंथेसिस. यहाँ भी स्पेलिंग मिस्टेक है, ए नहीं होना चाहिए था, ओ होना चाहिए था. इनबॉर्न एरर ऑफ थायराइड हार्मोन सिंथेसिस इंक्लूड्स defective synthesis of thyroxine, defect in iodide transport, thyroid peroxidase defects of organification and coupling, defects of thyroglobulin synthesis, defect in deiodination, defect in thyroid hormone transport. So if you know how the thyroid gland and thyroxine is formed in the thyroid gland, you know the different steps from which finally end product of thyroxine is produced. So if there is defect in any of the steps in the formation of thyroxine, that will be considered as inborn error of thyroid hormone synthesis, and that is the second reason of congenital hypothyroidism. The third reason of congenital hypothyroidism could be thyrotropin deficiency, meaning that the problem is with the hypothalamus. Hypothalamus is supposed to produce the thyrotropin. That thyrotropin act on the anterior pituitary to produce thyroid stimulating hormone. That thyroid stimulating hormone act on the thyroid gland to produce the thyroxine. So if a baby is having thyrotropin deficiency, so as there will be no thyrotropin, there will be no activation to the anterior pituitary to form the thyroid stimulating hormone, and as there is no stimulation to the anterior pituitary to form the thyroid stimulating hormone will be less, and as a result, the thyroid gland will not produce the thyroxine. So one of the reason of congenital hypothyroidism could be that the fault is in the hypothalamus, and that is not producing the thyrotropin. Or another reason could be thyrotropin hormone unresponsiveness, meaning that the hypothalamus is producing the thyrotropin, but when it is reaching to the anterior pituitary with the order to produce the thyroid stimulating hormone, the anterior pituitary is not giving any lift to that. So there is thyrotropin hormone unresponsiveness. Another reason of congenital hypothyroidism could be thyroid hormone unresponsiveness, meaning that the thyroid gland is producing the thyroxine, but when the thyroxine is reaching at the cellular level to perform its function, the cells are not responding to that. So you say there is receptor defect in the cell wall. That's why the thyrotropin is not able to enter into the cell. So this is called thyroid hormone unresponsiveness, when at the peripheral level the cells are not responding because of the lack of receptor in their wall for thyroxine. Now, the acquired hypothyroidism, meaning that there was no fault to start with, but the child later on developed hypothyroidism. That is called acquired hypothyroidism, and one of the causes autoimmune, Hashimoto thyroiditis. Second is polyglandular autoimmune syndrome type 1 and type 2. These are very rare causes of acquired hypothyroidism. Then there are iatrogenic. They are relatively common causes of acquired hypothyroidism. For example, accidentally the baby or a child has taken the propyl thiouracil or methimazole or iodide or lithium, that resulted in damage to the thyroid gland, or the thyroid gland was exposed to irradiation, or child has taken accidentally radioactive iodine, and that has resulted in damage um, to the thyroid gland, or because of some tumor of the thyroid, the surgeon has done the thyroidectomy, and that resulted in hypothyroidism, and the patient will be needing to take the thyroxine for life because the thyroid has been removed because of some, for example, tumor of the thyroid gland. So these are the iatrogenic acquired causes of hypothyroidism, in which you have propylthiouracil, methimazole iodide, lithium ingestion, or irradiation of thyroid gland, or taking radioactive iodine that destroys the thyroid gland, or thyroidectomy was performed because of some reason that resulted in acquired hypothyroidism. So the causes are autoimmune or iatrogenic. Beside these systemic diseases, some systemic diseases can also affect the thyroid gland. For example, cystinosis, it's a metabolic disorder where the cystine is not metabolized properly, and excessive amount of cystine gets deposited in the thyroid gland that results in damage to the thyroid, and that results in hypothyroidism. Similarly, Langerhans cell histiocytosis, it's a malignant condition that can affect the thyroid gland also, and that can result in hypothyroidism. Or sometimes there is goiter, that is in tumor of the thyroid gland, that could be congenital or acquired tumor that results in increased size of the thyroid gland, and that could be one reason of hypothyroidism. So after knowing the different types of hypothyroidism and what are the clinical features of hypothyroidism at the neonatal age and the infantile or children age, and after knowing that the hypothyroidism could be congenital and acquired, and what are the congenital causes and what are the acquired causes, now we should move to how to investigate a suspected case of hypothyroidism. So newborn screening is done. The condition is screened for as part of the newborn blood spot screening program. Between day 5 and 8 of life, a sample of blood is taken from the baby by pricking their heel. Whenever you are pricking the heel of a baby, make sure that you don't prick the heel at the center of the heel, because that can lead to plantar fasciitis. Always prick at the lateral aspect of the heel. That will be giving you the sample, and that will be not damaging the plantar fascia. So between day 5 and 8 of life, a sample of blood is taken from the baby by pricking their heel. This blood is collected as a spot on a special card, which is sent to the laboratory to test for several of the more common inherited conditions, including congenital hypothyroidism. For example, phenylketonuria can be diagnosed at the congenital in the earlier stage of the life. Similarly, congenital hypothyroidism can be detected by this screening test. And the idea behind this doing this screening test is that if you detect the congenital hypothyroidism in the earlier stage, you can give the thyroxine at the earlier stage, and you can prevent the child from developing cretinism. A level of thyroid stimulating hormone is used for screening of hypothyroidism in neonates. But for example, that screening was not done, and the child came to you, say, at the 8 days or 10 days of life, and you want to screen that child for hypothyroidism. So what you will do, you will perform the thyroid stimulating hormone level of the child. Level of thyroid stimulating hormone is used for screening of hypothyroidism in neonates. And what do you expect to see? Increased level of thyroid stimulating hormone in primary hypothyroidism. So when the thyroid gland is not producing the thyroxine, it will give feedback to the anti-pituitary that there is deficiency of thyroxine. So the anti-pituitary, in response to that, will be producing more thyroid stimulating hormone, so that the thyroid gland may start working. So if you see thyroid stimulating hormone level increased, then you may suspect that this is a case of primary hypothyroidism, as because the thyroxine is not being produced, it gives feedback to the anti-pituitary that thyroxine is deficient. To respond to this condition, the anti-pituitary starts producing thyroid stimulating hormone in increased amount, and that is how you diagnose that, yes, this patient, I have done the thyroid stimulating hormone level of this child, and as the thyroid stimulating hormone level is elevated, this is indicating me that this patient is having primary hypothyroidism. And as we have discussed, there are three types of hypothyroidism: primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism. Primary hypothyroidism is when the fault is in the thyroid gland. Secondary hypothyroidism is when the fault is in the anterior pituitary. And tertiary hypothyroidism is when the fault is in the hypothalamus. So if you see an increased level of TSH and decreased level of thyroxine, that is most likely reason is primary hypothyroidism. Serum TSH levels elevated in primary hypothyroidism or compensated hypothyroidism because of some deficiency of thyroxine. Because of any reason, whenever there is deficiency of thyroxine, the anterior pituitary starts producing more amount of thyroid stimulating hormone. So if you see elevated thyroid stimulating hormone levels, you should consider primary hypothyroidism or compensated hypothyroidism. uh, and should be low or within the reference range in cases of pituitary or hypothalamic etiologies. So if the hypothyroidism is because of thyroid stimulating hormone deficiency or thyrotropin releasing hormone deficiency, in that case the TSH level may be normal or low. Isolated TSH deficiency is far less common than multiple anterior pituitary hormone deficiencies. So usually isolated TSH deficiency is very rare. If there is TSH deficiency, you expect along with that I might be having growth hormone deficiency in this child, or I might be having adrenocorticotropic hormone deficiency in this child. So isolated thyroid stimulating hormone deficiency is rare. So you will be seeing signs of hypopituitarism, meaning along with the TSH, decreased production of TSH, that patient is showing you decreased production of growth hormone, decreased production of adrenocorticotropic hormone, decreased production of follicular stimulating hormone or luteinizing hormone. That is the anterior pituitary, the hormones that are produced by the anterior pituitary will be found diminished along with thyroid stimulating hormone. Usually isolated TSH deficiency is far less common, and the multiple anterior hormone deficiencies are found out, and that is a case of pituitary hormone deficiency. So you should be clear about it that if the TSH level is elevated, the cause is primary hypothyroidism. Supposing if the patient is thyroxine hormone level is low and TSH is also low, you will be surprised. I was expecting the TSH should be raised. Why the TSH is not elevated? The reason is might be this patient is having hypothyroidism because of problem at the anterior pituitary level, and thyroid stimulating hormone is not being produced properly. That's why the thyroid stimulating hormone level is low, and as the thyroid stimulating hormone is low, naturally the thyroxine hormone level will be low. So that's how you can, and if that decreased thyroid stimulating hormone is associated with other pituitary hormone deficiency, then you will suspect that this is most likely fault is in the pituitary. So T4 is present in both the free state and bound to thyroxine binding globulin. Total T4 assays measure T4 in both states and are useful to establish the diagnosis of primary hypothyroidism and to assess response to treatment. So if you are suspecting primary hypothyroidism, you order serum T4 level that will be low and TSH level that will be raised. Free T4 should be directly measured. Serum free T4 should be measured when secondary hypothyroidism, that is pituitary TSH deficiency, or tertiary hypothyroidism, that is hypothalamic thyrotropin releasing hormone deficiency is suggested. So if you are suspecting that might be this patient is having secondary or tertiary hypothyroidism, that is fault is either in the pituitary or hypothalamic, in that case you order free serum T4 level and TSH level. And in those cases where you are suspecting primary hypothyroidism, that is fault is in the thyroid gland, in that case you can order serum T4 and serum TSH level. And in cases where you are suspecting secondary or tertiary hypothyroidism, you usually order serum free T4 and serum TSH level. The confirmatory studies in infants, if the serum total T4 is less than 85 nanomole per liter, with thyroid stimulating hormone more than 40 international unit per liter, congenital hypothyroidism is likely. So if the T4 is low and TSH is high, most likely this is congenital hypothyroidism. If total T4 is low and serum TSH is not elevated, then thyroxine binding globulin deficiency, central hypothyroidism, or euthyroid 6 syndrome should be considered, and repeat testing may be needed. Serum free T4 concentration is normal in thyroxine binding globulin deficiency. Normal TSH in the presence of low T4 and free T4 concentration suggest secondary or tertiary causes of hypothyroidism. So one should be very clear that what I'm going to expect. If the T4 is low, you expect the TSH should be high in case of primary hypothyroidism. But in case of secondary or tertiary hypothyroidism, the situation could be different. Your thyroxine level may be low, as well as your TSH level may be normal or low. So it will indicate that it could be a case of secondary or tertiary hypothyroidism, meaning that the fault is in the anterior or hypothalamus. And how can we find out that where is the fault? As we have discussed earlier, that the secondary hypothyroidism usually don't occur in an isolated fashion. It is associated along with the deficiency of other anterior pituitary hormones. So and there is a printing mistake in the earlier, that is in the secondary hypothyroidism, signs of associated hypopituitarism, for example poor feeding, hypoglycemia, and physical findings, for example midline defects, micropenis, support the diagnosis of pituitary hypothyroidism. All such infants should be screened for other pituitary hormone deficiencies, like you would like to check the growth hormone level, you would like to check the adrenocorticotropic hormone level, you would like to check the luteinizing hormone level, would like to check the follicle stimulating hormone level, meaning those hormones that are produced by the anterior pituitary. If they are deficient and the TSH is deficient, most likely causes that this is secondary hypothyroidism. The problem lies with the pituitary gland. Serum anti-thyroid antibody test findings do not facilitate the diagnosis of hypothyroidism and only serve to establish a diagnosis of chronic lymphocytic thyroiditis and indicate the risk of subsequent development of hypothyroidism. So in a female, for example, you are suspecting chronic lymphocytic thyroiditis, you would like to perform this test, serum anti-thyroid antibody test. Antithyroid peroxidase and antithyroglobulin antibody titers are elevated in 90 to 95% of children with chronic lymphocytic thyroiditis. So if you are suspecting chronic lymphocytic thyroiditis, in that case, you will be ordering serum antithyroid antibody test. If they are elevated, that will favor the diagnosis of chronic lymphocytic thyroiditis. So you will be ordering T4 level, you will be ordering TSH level, and you may ask for serum antithyroid antibody test if you are suspecting chronic lymphocytic thyroiditis. Now the radiological finding, these were the blood tests that you performed in a patient with hypothyroidism. Now the radiological findings. Absence of, this is again a spelling mistake, distal, it's not distal, it's distal. Absence of distal femoral epiphysis. If you do the x-ray of the knee joint of a newborn baby, you should see epiphyseal centers at the knee joint level, femoral epiphysis. But if you do the x-ray of the knee joint of a neonate and you don't see any distal femoral epiphyseal centers, that in that case that will favor the diagnosis of congenital hypothyroidism. So if someone asks you that there is no laboratory facility available in the village where you are working, but there is an X-ray facility is available, how can you diagnose congenital hypothyroidism? Then in that case you will say, okay, fine, I would have loved to have the serum T4 level and the serum TSH level to find out congenital hypothyroidism. But if the blood tests are not available because of the absence of laboratory in this area, and you are saying that only X-ray facility is available, kindly do me a favor and do the X-ray of the knee joint of this newborn baby. I want to see whether there is absence of distal femoral epiphysis. If there is absence of distal femoral epiphysis, that will indicate congenital hypothyroidism. So you can diagnose congenital hypothyroidism even with the X-ray alone. Epiphyseal dysgenesis will be seen, and if you do the X-ray of the thoracolumbar spine lateral view, you will see chin type appearance of the anterior border of the 12th thoracic rib. Normally, Shrida, when you take the lateral view of the thoracic vertebral body, it's just like a brick. And if in that brick anterior aspect, you see in the lower portion, some beaking is taking place, that is a point you say that I'm seeing beaking at the 12th and the first lumbar vertebrae. And that is again a radiological finding in favor of hypothyroidism. And third thing is discrepancy between chronological age and bone age. One should be clear about what do we mean by these two terms. Chronological age is your actual age. For example, if you see a child who was born on, say, for example, 1st January 2016, and today is 12th September 2020. You say okay, your chronological age as you were born in 2016, and your chronological age is 4 years, right? So chronological age is your actual age that you discover from the time of your birth, the date when you were born. That is chronological age. For example, and what is the bone age? It is the age of the bone. So these two terms should be very clear. What do we mean by chronological age and what do we mean by bone age? Chronological age is your actual age. For example, you are 4 years of age. This is your chronological age. But for example, if you do the X-ray of the left wrist joint for detecting the bone age of this 4-year-old child, what do you expect to see? You expect to see 5 carpal bones in a 4-year-old child. But for example, in a 4-year-old child, you do the X-ray of the left wrist joint, and instead of 5 carpal bones, you only see 2 carpal bones. So you know that 2 carpal bones are seen at the age of 1 year. So you will say your chronological age is 4 years, agree, but your bone age is just 1 year because you are having only 2 carpal bones. And regarding the carpal bones, at the age of 1 year, you expect to see 2 carpal bones if you do the X-ray of the left wrist joint. And then each year, 1 carpal bone is added. For example, if someone asks you how many carpal bones you can see at the age of 1 year in a normal child, you will say at 1 year there should be 2 carpal bones. If someone asks you what should be the count of the carpal bones if the child age is 2 years, you say after the age of 1 year we add one. So at the age of 2 years, there should be 3 carpal bones. At the age of 3 years, there should be 4 carpal bones. And at the age of 4 years, you expect to see 5 carpal bones. Why? Because at the 1 year, you expect to see 2 carpal bones. Then each 1 year, 1 carpal bone is added. So if someone asks you what should be the how many carpal bones you will see in a 4-year-old child, you will say at the age of 1 year there are 2 carpal bones, and then at the age of 2 years 3, at the age of 3 years 4, and the age of 4 years 5 carpal bones. Okay, fine. So if you see 5 carpal bones, if you do the X-ray of the wrist joint, 5 carpal bones in a 4-year-old child, you will say, yes, your chronological age is 4 years and your bone age is also 4 years, because at the age of 4 years, I expect to see 5 carpal bones and your X-ray of the left wrist joint is showing me 5 carpal bones. So your chronological age and your bone age is the same. And that should be the normal scenario, that the bone age should be in compliance with the chronological age. So if you see a 4-year-old child with 5 carpal bones, you will say your chronological age is 4 years and your bone age is also 4 years. But for example, in a situation where you are dealing with a child who is having hypothyroidism, when you do the X-ray of the left wrist joint to see the bone age of that child, you might be seeing only 2 carpal bones, and you can tell the family, look, your child is 4 years of age. I was expecting to see 5 carpal bones, and I'm only seeing 2 carpal bones. Your child bone age is just 1 year. So this discrepancy between the chronological age and the bone age is the thing that is a point, radiological point in favor of hypothyroidism. So not only you can order the blood test, for example, free T4 level and the serum TSH level. Radiologically, you can also diagnose hypothyroidism by seeing the absence of distal femoral epiphysis in the neonate, seeing the beaking of the 12th or the first lumbar vertebra in the lateral view of the thoracolumbar spine, and by seeing the discrepancy between the chronological age and the bone age. Similarly, in the skull, if you do the X-ray of the skull, that will show large fontanelle and white sutures, and intersutural bones are also common in patients with hypothyroidism. And sella turcica is also enlarged and round. Beside doing the blood CP, beside doing the serum TSH level, and beside doing the free T4 level, and beside doing the radiological investigation for hypothyroidism, thyroid scintigraphy with technetium sodium pertechnetate or sodium iodide scan can help to pinpoint the underlying cause of hypothyroidism, in which you give injectable some solution into the vein, and you see whether that get concentrated in the thyroid gland or not. But if you take the scanning and there is no accumulation of that dye in the thyroid, it means that there is some problem with the thyroid gland that is not accepting the dye. So that's you can find out that yes, this is primary hypothyroidism, because I have injected the dye, this dye should have reached to the thyroid and get concentrated there, but when I have taken the photograph, there is no uptake of dye from that area just above the thyroid, meaning that there is some problem with the thyroid. That is, it is primary hypothyroidism. So this is one another investigation, thyroid scintigraphy with technetium sodium pertechnetate or sodium iodide scan, that can help to pinpoint the underlying cause of hypothyroidism. So now you know what is hypothyroidism, what is primary, what is secondary, what is tertiary hypothyroidism, and what are the clinical features of hypothyroidism in a neonate or an infant or child, and how do you investigate a child who is having hypothyroidism. Then we reach to another investigation that you can do in a suspected case of hypothyroidism, that is the electrocardiogram. If you see the ECG of a child with hypothyroidism, what do you expect to see? Low voltage P and T waves. Normally, you remember the ECG waves, and there is a speed breaker type of wave that is called the P wave to start with, and then there is a horizontal area, and then there is QRS complex, a small deflection of Q, and then a big deflection of R, then another small deflection of S, and then after slight movement in front, there is again a speed breaker type feeling, that is the T wave. So if you see the ECG of a normal PQRST complex, you will see that will be low voltage P and T waves with diminished amplitude of QRS complexes. And if you see that sort of thing, that will suggest poor left ventricular dysfunction and pericardial effusion that can be seen in a patient with hypothyroidism. So see, you can diagnose hypothyroidism by doing the ECG, by doing the radiological investigations, and by doing the blood tests. Now, वो जो गालिब ने कहा कि इब्ने मरियम हुआ करे कोई, मेरे दुख की दवा करे कोई, meaning that okay, you are a very qualified doctor and you know what is hypothyroidism, you know the causes of hypothyroidism, you know the clinical features of hypothyroidism, you know how to diagnose hypothyroidism by different blood tests, by the radiological test, by scintigraphy, fine, mashallah. But what about me? I am having delayed milestone, I am having failure to thrive, can you treat me, doctor? So the basic thing, all this ends up in over here, that if you have diagnosed hypothyroidism, do you know how to treat it? So treatment is luckily very simple. what you have to do, you have to start the child on thyroxine. Levothyroxine is the treatment of choice in neonates. The initial dose is 15 to 20 microgram per kilogram. One tablet of thyroxine is of 50 micrograms that is available in the market. So in neonates, you calculate initial dose by 15 to 20 microgram per kilogram. For example, you see a child who is having a weight of 2 kilogram, and that baby is brought to you at the age of 21 days of life with the complaints of jaundice which is persisting. You say might be this is a case of prolonged physiological jaundice, and let me check the serum TSH level of this child and free T4 level, and the T4 level, and you find that the T4 level is low in that 21 days old baby and TSH is markedly elevated. You diagnose that this patient is having congenital hypothyroidism, and most likely it is primary congenital hypothyroidism. So you can start the child on thyroxine. As the weight of the child is 2 kilograms, you give 15 microgram per kilogram, so you will be giving 30 microgram to that child to start with, or you can calculate the dose with the 20 microgram per kilogram. So in that case, the child, for example, is 2.5 kg, then 20 microgram multiply by 2.5 kg, that will lead to 50 microgram. And as you know, one tablet of thyroxine is of 50 microgram. So you can tell the family that your child has been diagnosed as a case of hypothyroidism, and from today I am starting this thyroxine in this child, and inshallah it will help the child in having a growth and the normal mental development. And you have to give this medicine early in the morning before breakfast, and then you continue to monitor that child TSH level in the forthcoming visits, so that you can adjust the level of your medicine that you are giving between this range of 15 to 20 microgram per kilogram. But suppose if you don't see a baby at the neonatal age, and a child is brought to you at the age of, say, for example, 4 years, with short stature and delayed development, and you investigated the child and you find out that this patient is having hypothyroidism. So in a child, you don't give the dose of 15 to 20 microgram per kilogram. The dose of thyroxine for a child is 4 microgram per kilogram per 24 hour. For example, the child is 4 years of age, and when you did the weight of the child, you find that the weight of the child is 12.5 kilo, 12.5 kilogram. Now you know that the dose I have to calculate with the dose of 4 microgram per kilogram per 24 hour. As the child weight is 12.5 kg, you multiply 4 with the 12.5, and that will give you 50 microgram. So again, you will say, okay, yes, your child is having hypothyroidism, and I am starting this medication with a dose of 4 microgram per kilogram per 24 hour. And as your child weight is 12.5 kg, multiplying it 4 microgram, it will lead to 50 micrograms. So this tablet is of 50 micrograms. So you have to give this one tablet to your child before breakfast, and inshallah that will help in improving the child's condition by decreasing the hypothyroidism that the child is having by this addition of thyroxine that is given in the form of medicine. But in an adult, for example, he developed hypothyroidism because of thyroidectomy done because of, say, for example, because of some thyroid issue, then in that case, the adult will be needing the dose of 2 microgram per kilogram per 24 hours. For example, the child adult is of 75 kilogram. So 2 microgram per kilogram means 75 kilogram child, 75 kilogram adult, it will be 2 multiplied by 75, 150. And as you know, one tablet is of 50 micrograms. So you will advise that adult to take 3 tablets of thyroxine before breakfast. So this brings to near to the end of our lecture. So this is the dosage. Now, level of T4 and T4 and TSH should be monitored at recommended intervals, monthly in the first 6 months of life, and then every 2 to 3 months between 6 months and 2 years. So if you are managing a neonate with hypothyroidism, what you have to do, you start the treatment with the dose of 15 to 20 microgram per kilogram, and you first initially in the first 6 months of life, you monitor the level of T4 or free T4 and TSH on monthly basis. And after the 6 month of life, then you can do after every 2 to 3 months, from the 6 month till the 2 years of age. And after the 2 years of age, you might be doing this investigation may be after every 6 months. Early diagnosis and adequate treatment from the first week of life results in normal linear growth and intelligence. Without treatment, affected infants are profoundly mentally deficient and growth retarded. So the bottom line is take him messages that one should diagnose the hypothyroidism as soon as possible, because earlier you start the treatment, the better will be the outcome. In the case of concomitant hypopituitarism with corticotropin deficiency or any other cause of suspected adrenal insufficiency, glucocorticoid replacement should always precede thyroid hormone replacement. For example, you are dealing with a case of hypothyroidism where the problem is in the pituitary gland. So if there is will be considered as secondary hypothyroidism, as we have discussed that in the primary, the fault is in the thyroid gland. In the secondary hypothyroidism, the fault is in the pituitary, and in tertiary hypothyroidism, fault is in the hypothalamus. So if you with a child who is having pituitary as the culprit, or in other words, you are dealing with a child who is having secondary hypothyroidism, one should be very clear about it, that don't give thyroxine to that child, because if you give thyroxine only to that child, that thyroxine will lead to enhanced metabolism from thyroid replacement. And when there will be enhanced metabolism, there will be more need of adrenocorticotropic hormone. And as this patient is having corticotropin deficiency because of the fault in the pituitary, that may result in adrenal crisis. So one should be very clear about it, that am I dealing with the case of primary hypothyroidism or secondary hypothyroidism? If you are dealing with the case of primary hypothyroidism, no issue, just give thyroxine. But if you are dealing with the secondary hypothyroidism, take care that you are not giving only thyroxine to that child. You will be giving, you will be checking for other hormones, and if those hormones are deficient, for example, there is deficiency of adrenocorticotropic hormone, you should replace that before starting the thyroxine. I thank you very much for your attention. If you have any questions, you can ask in the chat box and I will try to answer.
जी सर, एंड करना है, क्वेश्चन आंसर करना?
जी हाँ, अब ये जो चैट बॉक्स में अगर इन्होंने कोई क्वेश्चन पूछने हैं तो पूछ लें।
अच्छा सर, ठीक है सर।
चैट बॉक्स में टाइप कर दें, मैं आई विल ट्राई टू आंसर।
जी जी, अभी तक आया नहीं सर कुछ।
ठीक है, तो 1-2 मिनट वेट कर लेते हैं, और अगर कोई नहीं आया तो खुदा हाफिज। एक क्वेश्चन आया है, आफ्टर हाउ मच ड्यूरेशन ऑफ फिजियोलॉजिकल जॉन्डिस वी शुड सस्पेक्ट दिस? यूजुअली द जॉन्डिस और फिजियोलॉजिकल जॉन्डिस गेट सेटल्ड बाय द 10 days of life. It starts from the 48 to 72 hours, reach its peak at 6 to 7 days of life, and then by the age of days, that physiological jaundice is no more there. But supposing if it is persisting, then you should be thinking that might be, let me do the TS patient, might be this patient is having this prolongation of physiological jaundice because of congenital hypothyroidism. I thank you very much for your attention.
Okay, sir. Allah Hafiz. Take care.